A standard clinical spirometry printout often appears as a chaotic mess of overlapping mathematical curves and hundreds of raw data points. Effective clinical interpretation relies on a rigid, sequential logic gate rather than the recognition of complex geometric patterns. By filtering the data, we isolate three specific metrics: FEV1, FVC, and the FEV1 over FVC ratio. These numbers measure the basic physical capacity of the respiratory system, how much air the lungs hold, and how fast that air is exhaled. Using these three values as a starting point provides a repeatable framework for categorizing a patient's respiratory pathology in under 30 seconds. FEV1 follows the F is for first mnemonic. It represents the volume of air a patient forcibly exhales in the exact first second. FVC represents full. This is the maximum volume of air exhaled after a full inspiration. The FEV1 to FVC ratio expresses the relationship between initial expiratory speed and total lung volume. This ratio is the primary sorting mechanism for the algorithm, determining which diagnostic pathway to follow. Understanding these three metrics is the only prerequisite needed to build a functional diagnostic model. Step 1 of the 1-minute algorithm begins with the ratio. This determines if the airway road is physically blocked. If the ratio is low, the patient meets the criteria for obstruction. In obstructive disease, narrowed airways slow the exit of air. While total volume eventually leaves the lungs, the amount escaping in that first second is significantly restricted. Because FEV1 drops much faster than total volume, the resulting ratio is mathematically pushed downward. The common causes for this pattern can be remembered by the ABC mnemonic: asthma, bronchiectasis, and COPD, along with cystic fibrosis. On a flow volume loop, this slow expiratory flow changes the normal triangular shape into a scooped-out curve, the visual signature of obstruction. Obstruction means out is difficult, manifesting as narrowed airways, a scooped loop, and a diminished ratio. If the initial ratio is normal or high, we move to the second branch of the algorithm. Step 2 is to check the total volume, or FVC. If this value is low, we shift our focus to possible restriction. Restriction occurs when lungs are in a small box. Conditions like fibrosis prevent expansion, so the patient cannot get enough air in. The ratio remains normal because first-second flow and total volume drop proportionally. The lung is small, but airways are unblocked. On a volume time curve, the flow rises sharply but plateaus early. This shows that while air moves quickly, the total capacity of the lung is severely reduced. Restrictive causes follow the PFN mnemonic: pulmonary fibrosis, fluid or pleural disease, and neuromuscular or chest wall causes. Restriction means the patient cannot get air in, resulting in reduced lung volumes with a preserved flow ratio. While the ratio and FVC categorize the primary defect, clinicians use specific secondary tests to confirm these findings. For an obstructive disease pattern, we check for bronchodilator reversibility. If airflow improves significantly after treatment, it suggests asthma. In COPD, the airflow limitation is generally persistent and does not fully reverse. In the restrictive pathway, we must avoid the FVC trap. A low FVC does not always mean restriction. In severe obstruction, air can become trapped in the lungs, artificially lowering the exhaled volume measured by spirometry. Because of this, spirometry only suggests restriction. To confirm the diagnosis, we must measure total lung capacity, or TLC. Finalizing a restrictive diagnosis without a TLC measurement risks mismanaging patients who may actually have severe obstructive disease. This logic gate, ratio, FVC, and confirmation through TLC or bronchodilators, provides a structured diagnostic pathway. We can consolidate this entire sequence into a simple matrix for clinical recall. In obstructive disease, FEV1 and FVC may both drop, but the defining signature is the plummeting ratio. In restrictive disease, the FVC drops significantly, while the ratio remains normal or even slightly elevated. The mnemonic O is for out represents obstruction, dropping the ratio, while R is for reduced volume represents restriction, dropping the FVC while preserving that ratio. Ratio first. If it is low, think obstruction. If the ratio is normal but the FVC is low, consider restriction and check the TLC. This approach functions like a systematic ECG interpretation, providing a repeatable protocol that converts complex pulmonary data into specific clinical findings.